Hello. I wanted to open with a thesis: sophistication through simplicity. In healthcare technology, it's tempting to solve problems by building more devices, more models, more dashboards. Our premise is actually quite the opposite. Standards create interoperability, and FRK, Fall Risk Kit, is the open source framework that turns existing standards into a working ecosystem for fall prevention. One more thing before we start. If we are successful, reported falls will rise because capture will rise. Lowering today's numbers doesn't take innovation, it takes fragmentation. Lucian, why don't you take us to the problem?
43% of major falls in the nursing homes are not reported to CMS. Think about that for a second. That is not a rounding error. That is almost half of the qualifying events. 1 in 4 in adults over 65 will experience a fall every year. That's the scale we're talking about that we fail to see. And the estimated cost of $80 billion, that's the price of the invisible tail. This is a huge failure of the healthcare system that is affecting the patients. There's a clinical failure because of independence loss, fear. There's a data failure because fall events are scattered across nodes, claims, and incident reports without a structured format. The system failure, near falls, earlier warning systems are almost never captured. This is a data failure scale. Before we talk about FRK as a solution, I'd like to introduce to you the clinicians who help us validate our problem statement. Dr. Caitlin Jones, she is a board-certified geriatrician, internal medicine physicians, and program director of the Geriatric Fellowship and a medical director of clinical unit. And in contrast with me as a clinician dealing with elderly patients, or David, who's a software engineer who has been affected by falls in his private and family life, Dr. Jones is dealing with falls as a problem on a daily basis, multiple times a day. So we have engaged with Dr. Jones, trying to specifically validate a problem statement, pressure test the FRK intervention model, and confirm that what we're building reflects the clinical reality. A simple question we asked Dr. Jones is, in her experience, what is the single greatest predictor that older adults will fall? And the answer cuts to the heart of why FRK exists and why underreporting is just a compliance problem, but a clinical one.
What is the greatest risk for a fall and what is the greatest predictor of future falls? It's having a prior fall.
What are the major root causes for these failures? Clinical data that lives in electronic health records is very episodic. The sensor that exists but is so fragmented is not synchronized and hardly ever reaches the record. Environmental data is invisible, is never captured. Outcomes are underreported. So the gap is infrastructures. But here's the news. The infrastructures, it already exists. The standards have been defined, but just nobody has connected this yet. That's what FRK does. Listen to Dr. Jones, who is living with these problems, and she actually describes what she needs. And when we asked Dr. Jones what she wished she had at the point of care, her answer named 2 of the tools by name.
Do they have any prior history of falls? What is their assistive device use? So on and so forth. What is their substance use history, symptoms and prodromes surrounding the fall, and really obtaining that clinical fall history. Now, as you alluded to, I worry that my role is probably too late. I see a person after they have fallen. So ideally, how can we prevent it and how can we appropriately screen for it? I know it's overused. attempted to be overused, but implementation is challenging. But could annual wellness visit be an opportunity, is what I wonder. I know in our geriatrics clinic, we officially do a 6 meter walk test. So we have gait speeds for older adults. So we know those who have a slow gait speed and increased risk of fall. And I think that there's ways, like you're indicating, to really automate our fall risk screening. So even something as simple as the study checklist from the CDC and doing a gait speed, I think could get us that indication of maybe a small percentage of those 1 in 3 older adults who will fall, that we can ideally prevent that fall before it even occurs and I see them in the hospital.
They both exist for over a decade, but none of them are actually implemented in a workflow as of today. What are these four-layer framework that we have identified while we're researching this program? So, Agency for Healthcare Research and Quality, they tell us what data needs to be collected. The SMART and FIRE, that stands for Substitutable Medical Application Reusable Technology on Fast Healthcare and Interoperability Resources. This is a protocol for interoperability across electronic health records, and this tells us how to transmit the data based on guidance from ONC, the Office of National Coordinator for Healthcare Technology. STEADY. Now, this is the brains of the program. So this is a CDC initiative launched in 2012. And so this is a decision tree. They provide healthcare providers the tools and resources to implement for fall preventions. The most interesting piece of the puzzle is CMS Access. This is a program launching in July 2026. And this is a financial incentive that pays for these outcomes. And so the FRK basically exists, but it's on paper. And so what we're trying to do is to make this digital, sensor-fed, and alert-driven.
Before I show you the architecture, I want to be clear about what FRK is not. See, it's not a device. It's an open source software development kit. No hardware approvals, no vendor lock-in. It is not just AI, it's an interoperability platform. AI serves the decision layer. The platform is the value. And it's not another EHR module. It's infrastructure for a new care model. FRK transforms fragmented signals into longitudinal, actionable clinical intelligence. Now, the clinician, Dr. Jones, who validated this model, had a specific vision for what it should do. Let's listen now.
So current state, how I know about falls is I ask the patient and their family directly. I wish there were an automated way to do it, but it is direct history taking at this time that I learn about fall history and get those details I was telling you about earlier. I do think there's huge opportunity in this age of technology. Wearables even tell you when there is a fall. Can we put a wearable on an older adult and have a truth fall report, so to speak? I think that could be very exciting, particularly for a selected group of older adults who, for example, are cognitively intact and community dwelling. I think there lies great opportunity.
A truth fall report. That's not a metaphor, that's a technical specification spoken in clinical language. And it's exactly what FRK delivers. Here's the architecture that makes it possible. 5 stages: sensor to clinical decision. See, a wearable captures continuous motion data. A secure AWS gateway, already covered under a business associates agreement, receives it. A transform layer converts that raw data into a FHIR observation and adverse event resources. Health Lake stores it longitudinally. And a steady aligned alert surfaces in the clinician's workflow. Now, our AI strategy, most health AI projects pick the most sophisticated model they can run. We've inverted that. Our algorithm is chosen by data set intent, not complexity. Let me show you these three cards. Discover, K means clustering. It surfaces patient risk profile from day one before a single fall has been recorded. Then there's classify, decision trees, explainable, auditable logic. A clinician can review and a regulator can inspect. Compare, K nearest neighbors, case-based reasoning, patients like this one. Support vector machines and a neural network are future extensions, not default answers. Let's take a look at the project plan. 36 months, 3 phases. Let's start with phase 1, which is where we do the build. The first 6 months is really focused on the FHIR SDK core, the AWS infrastructure, and the steady CDSS algorithm, as well as GitHub documentation. Phase 2 is where we look to validate, months 7 through 18. This focuses on IRB approval, pilot site, HIPAA and FDA software as a medical device compliance audit. And then phase 3, this is where we look to scale, months 19 through 36, multi-site deployment, CMS access enrollment. And here's what separates this plan from just being a wish list. We have a grant strategy that runs in parallel every month across all 3 phases. We've identified 2 federal grants, $4.7 million for health modernization and $4 million for falls prevention. And we expect more to come online as well throughout the course of the pilot. This is not a self-funded pitch. It's a grant-aligned capital strategy.
Are 3 main groups of stakeholders that we have to be mindful of. The clinical stakeholders, including the geriatricians, primary care physicians, the nurses that receive these alerts. The technical stakeholders are electronic health records, the manufacturers of the wearables, and of course the cloud infrastructures where the data is hosted. And of course the regulatory payer like CMS, ONC, ACL stands for Administration for Community Living. You have to be mindful of all of these structures. And for example, if you want to implement AI, a tremendous valuable guidance, Joint Commissions and FDA, the responsible use of AI healthcare that contains 7 elements, the FDA good machine learning principles has 10 principles. So FRK must be mindful of all of these guidances and programs. That's how you end up with the clinical trustworthy, legally defensible, and organizational adoptable project.
Now let's look at the budget and the ROI. Year 1 cost per facility, $122,000 to about $181,000. Year 2 and beyond, $46,000 to $81,000. The implementation costs are deliberately front-loaded. Now the return, fall injuries avoided, $270,000 to $600,000 per facility per year. CMS penalty avoidance, $100,000 to $200,000, and access model revenue, $400,000 to $800,000. Total annual value would be $770,000 to $1.6 million per facility. Projected ROI, 4-to-1 to 8-to-1. That gives you a break even, 2 to 3 falls prevented per year per facility, and that's just the bar.
There are 2-phase KPI approach. In years 1 to 3, we hope to establish a baseline by dropping the underreporting and having 100% compliance of the full records in the FHIR observation plus adverse events. And year 3 and beyond, that's where we start actually measure our outcomes. We hope to achieve at least 20-25% reduction of falls by year 5, And 80% of high-risk patients get a documented interventions within 48 hours of a steady driven alert. The data for these programs will go into CISU type of dashboard, and the initial improvement reporting will result in an increase in the perceived events. That's what we hope to distinguish by creating this baseline, so leadership will not misread this as this initial rise as a failure.
So I know there are many fall pathways, but I think that we need to really consider the interplay of all cognitive and physical domains with fall workup, which I'm so excited to hear about the work that you're doing.
Now let's pick up and talk about leadership. We just heard fall risk kit. There are issues with patients, cognitive, physical, social. You hear about these 3 domains for one patient. You can't build a solution to a multi-domain problem with a single domain team. And this is where Dr. Lucian Vlad is the clinical authority on our leadership team for this project. He's a practicing physician, a daily observer of high fall risk patients, and a clinical champion in the field of medical informatics. For myself, I'm the technical authority, a software engineer with cloud AWS architecture expertise. I designed the FHIR SDK and the regulatory compliance framework. Clinical authority plus technical authority means HIPAA and health equity are built in to FRK, not bolted on. And now I'm going to hand this back to Lucian to take us home.
In closing, the four areas of impact at scale for our program include the quality of care, where we're hoping the fragmented care now becomes structures and actionable data. The health disparities, our aim for this project is to make sure that patients who cannot self-report will be reached a lot easier. The health equity means that open source, any organizations, any size can adopt these principles. And the delivery through FHIR native plugins, EHR already exists. FRK is not a product. FRK is an infrastructure for a new model of care. Thank you.